Well, good afternoon, ladies and gentlemen, and a warm welcome from a magnificent Cape Town. There's not a cloud in the sky, it's beautifully warm outside, and we hope there'll be some rain sometime. It gives me great pleasure to welcome this afternoon our speaker, Justyna Wojno. She's been on the platform before. She's somebody that needs no introduction, and I asked her, how would you introduce yourself? She said, the amazing and immaculate microbiologist who's an expert on vaginal well-being. So that, in fact, who she is, Justyna Wojno, is a in charge of the PCR lab in the Western Cape for Lancet. So she's nobody else can approach her without any expertise she has in her knowledge of vaginal well-being. I was just saying just now off air that it's amazing, Steve, how many people have introduced products for vaginal well-being. There's Gynaflor, there's Polygynax, and there's another name that I can't use because it's called Cookie Fresh, and I don't think it's Steve, put that away, please. So, so there's all sorts of products, and the thing about Justyna is that being an expert on the vaginal microbiome, and she's going to be speaking on the disrupted vaginal microbiome this afternoon, is that these are medications and products that don't have antibiotics. And there's been many people available, many people have asked after them, and we're going to hear this afternoon how successful, in fact, they are in treating a woman's complaint of vaginal discharge that is not an STD that has a disrupted vaginal microbe. And a special welcome to Steve. He's our co-producer and co-presenter this afternoon. And of course, Chris, it would be wrong for us not to mention Chris's expertise. So without further waste of time, Justyna, it's wonderful to have you, our immaculate microbiologist from Lancet. We look forward greatly to hearing what you're going to be saying. Um, and if you could share your slides, please, Justyna.
Thank you so much for that lovely introduction. I was only joking about the immaculate amazing. It was only a joke, but thank you. I'll take it.
I wrote it down. I wrote it down
Very
so I can
kind.
relay it
Yes,
back.
I saw. Thank you. Okay, let's share my slides. Okie dokie. Is everybody able to see that?
We have that on our screen. Thank you.
Wonderful. Okay, I'm just going to put it into speaker mode. Okay, so we're going to be talking about the vaginal microbiome and discharges. And I do receive quite a lot of phone calls where an STD has been excluded, and I think that's always important, especially in our population and in any situation, because we do know that you can have normal disrupted flora together with an STI. So we definitely mustn't forget about those. But today I'm going to be focusing mainly on the non-STD discharges. And so we're going to be talking about a normal vaginal microbiota. We'll talk about non-STD discharges, and then we'll go through a couple of management options, and I'll go through some of the controversial ones that were mentioned. And let's have some fun.
Have some fun.
Yes. Okay, so unlike the gastrointestinal tract, so we all know diversity for gastrointestinal flora. Well, the vaginal microbiome is actually quite undiverse. It's quite boring. It's dominated mainly by lactobacilli and various lactobacilli. So Acidophilus, Rhamnosus, Crispatus, all these funny names. So about 90% of it is actually lactobacilli. And we do have some bifidobacterium as well. And the reason why this is important is because they produce a lot of acidity. This lowers the pH of the vagina, and this helps to prevent an overgrowth of other organisms. So particularly the Candida, as well as other organisms like E. coli and other bugs from the gastrointestinal tract. And this is important because it maintains a healthy epithelium and basically stops an overgrowth of everything else. So it's a low diversity. There's hydrogen peroxide and everybody's happy. So there are some other funnies like atopobium, etc. And remember, everybody's slightly different and it can vary. The normal is never completely exactly the same. And depending on your ethnicity, your age, And hormones, so, perimenopausal, that time of the month, that can vary. And that's why sometimes people actually suffer with thrush, with hormonal fluctuations, is because this microbiome does shift with hormonal changes, and also obviously with age. And that's why we see that we do have a candida overgrowth with age, because lactobacilli can become less dense.
Apologies to interrupt, Tina.
Yes.
I just see the slides froze.
Oh,
Would you mind just exiting and re-entering or resharing the slides
yes,
there?
no problem. I can definitely do that. Let me stop sharing. Okay, are you able to see it again?
Excellent.
Okay,
Perfect.
great. And now I'm stuck. Oh, there we go. Okay, so what disrupts the normal microbiome? Well, as I've mentioned, hormonal shifts have a massive impact. So during your menstrual cycle, this is affected, pregnancy affected, menopause certainly does, perimenopause as well. Sexual activity, so semen, multiple partners, unprotected sex, any douching, fragrance, soap, sitting in funny baths with funny oils. As we know, antibiotics as well have a massive effect on the gastrointestinal system, but that can also affect your perineum and then subsequently affect your vaginal microbiome. And then lifestyle factors like smoking, high sugar, and stress. And then any infections can also do this. And that can completely disrupt your vaginal microbiome, and that can result in a discharge. So there are a lot of non-infectious causes of vaginitis, and I've had cases where gynecologists have called me. We've excluded all of the causes, and we've found a dermatosis, or we found that the patient actually has some sort of a systemic medical disorder, or dermatological disorder. So sometimes you actually need to look a little bit further and go through the process, and a process of elimination. And I have mentioned antibiotics, I've mentioned low estrogen levels, and sometimes it's a matter of using some local or topical estrogens. We know that a lot of the douches and vaginal washes can be disruptive, so we have to be careful using them long term. Pregnancy, sexual activity, contraceptive use, and obviously any foreign objects that are retained in the area can cause a lot of disruption. Okay, so this actually, the slides should be after this. Apologies. So bacterial vaginosis is extremely common, and that's why a lot of the time we actually, in a setting where laboratories are not easily accessible, we actually do treat empirically for bacterial vaginosis, because it is probably the most common cause of a discharge. It can account to up to 50% of vaginitis cases. And the global prevalence is about 25 to 30% of females of reproductive age. This actually doesn't usually cause erythema, redness, and inflammation on examination. It usually has a thin, off-white discharge. It's quite homogeneous and can have a fishy odor. Usually, if you've got multiple sexual partners, this does increase your risk. And what actually happens is there's this shift in your flora. And remember, I said that it's not good to have a diverse amount of organisms. So you get these little cells where the facultative anaerobes attach to. A lot of Gardnerella vaginalis, which is typical, Prevotella, Bacteroides. Some of them we grow, some of them we can only see on microscopy, and that's why we do the BV score. And what happens is that you have this rise in your vaginal pH. And often you have a lack of lactobacilli, and those are the ones that keep these bugs at bay. So if you look at the diagnostic criteria, often you've done your Amsel criteria in the lab, and we can see it on the gram stain. There are some commercial tests, and if the patient is not symptomatic, one can actually observe, and sometimes BV can resolve without treatment. Obviously we can have side effects with antibiotics, because they can result in vaginal yeast infections. So, we usually look and see if you've got a vaginal discharge. Is there an odor? Are you about to have any vaginal surgery or procedure? or if you're pregnant and lactating, you may want to take it further. And in those situations, you may want to treat. So the standard, obviously, treatment would be metronidazole. And we do know that that's not a very nice drug to take. If you take it orally, you can have side effects like nausea, abdominal discomfort. There are the vaginal treatments, the metronidazole and clindamycin, which sometimes is not always available. So that's just to be aware of. Not everybody wants to take an antibiotic, and some are quite hesitant to take the metronidazole orally. Yeah, I will talk about some other options just now. But just
Can
to
I
give
just
you
ask you, sorry, Tina,
Yeah.
can I just ask you something? So if you do see this preoperatively, you should treat it, even if they've got no symptoms.
Yes.
What would the implications?
Generally we do. Yeah.
Yeah.
Generally we do. And also for pregnancy, we do treat because it can result in obviously increased inflammation, early rupture of membranes, etc., etc. So it is something that we do recommend treating, even if you are asymptomatic in pregnancy. Yeah.
Yeah, good.
So just the germs data from the National Institute of Communicable Diseases in South Africa. So they don't have an updated annual report, but they did this in 2018. And just to show you, for bacterial vaginosis, 46, so they did this sentinel surveillance at various sites, and they just wanted to have a look at, STDs versus other causes of vaginal discharge syndrome. And bacterial vaginosis was present in 46.5% of cases. So almost half of the cases actually had bacterial vaginosis. And then Candida was present in 20% of cases. So, it's quite a large and significant portion of cases. And if you notice the green pie bit, nothing was found in 22% of cases. So those could be the non-infectious causes of vaginosis. So obviously antibiotic use or foreign objects, age, etc., low estrogen, etc., etc. So just to be aware of the fact that it is very common, and we get consulted with this on a regular basis. So another entity which I have come across quite often, and not all laboratories actually report on these bacteria if they overgrow on a vaginal MCNS. I know when I worked at the NHLS, it wasn't something that was reported. We just used to report Neisseria gonorrhea not present, Candida not present, etc. Kind of the main pathogens. But an aerobic vaginitis is when you've got organisms such as E. coli or Klebsiella or group B streptococcus overgrowing. So unlike the anaerobes of the bacterial vaginosis, now you've got coliforms from the gut overgrowing. So once again, you've got an abnormal biome. There's an imbalance in your vaginal flora. You often have this itchy, burning, yellow, sticky discharge. You don't have an STD. And the treatment, actually, your aim is to try and decrease that inflammation, restore your normal flora. Often we give topical antibiotics. A lot of clinicians want to use orals, but I find that giving topical antiseptics or antibiotics often works quite well. And sometimes we combine that with steroids, especially if there's a lot of inflammation, because these bugs can be quite inflammatory. So that's also quite important, and we do see that quite a lot, especially in our elderly patients where their gut microbiome is not great, which means their perineal microbiome is not great, which means also their vaginal microbiome is not great, and with the low estrogen in that area as well. And they just have this red, horrible, inflamed vaginal area. So I just want to bring up, I know that Peter mentioned all these funny things that are on the market at the moment, and one of them that I've come across is fluomycin, which contains an antiseptic. So it's not an antibiotic per se, it's called diqualinium chloride. And what it's actually quite good at, because one of the major issues with a bacterial vaginosis syndrome is actually the biofilm. So the organisms almost produce like this jelly-like substance, and they hide away in the vagina. And what the fluomycin does is it actually disrupts the biofilm in order for the antiseptic to effectively get rid of the organisms. So those facultative anaerobes and those anaerobes that are sitting there. So there is an article that shows that it actually works quite well. So that's quite nice to see. And I have suggested this occasionally for patients that don't want to take the oral metronidazole. And we have had some success with that. So obviously I haven't written up a case report, but I have had some anecdotal feedback where this has worked quite well. It's an intravaginal tablet that we use for 6 nights. It seems to work quite well. Obviously, you can, in somebody who wants to try that, use that initially, see how it goes, and if it doesn't settle, one can then go onto your metronidazole and take it from there. So that is another option, which I think is quite a good one, because it's a local option without side effects. So I think that is something that one can consider, fluomycin, and it is freely available at a lot of the pharmacies. The other
Justyna?
option, yes.
Sorry, Justyna, can you just go back one to that's it, fluomycin. The other thing about this fluomycin is it's not contraindicated in pregnancy, so you can use it also in pregnancy. And we heard just now why pregnancy treatment is important. So this is something you can use from the beginning of pregnancy.
Can I just also
Thank you, Peter.
Can I just ask while we're on that, so the Metrogel versus the oral metronidazole, are there any advantages of either, or can you use them?
So there is a slightly better efficacy for the oral versus the but it is minuscule, and then metronidazole is generally found to be more effective than the clindamycin, but also not by, I mean, the percentages are also not amazing. So yeah, generally, so that's why it's listed like that in the guideline as oral first, Metrogel second, and Dalicin third, or the clindamycin third. But not a lot of difference. Yeah. Are you just a question? Are you still able to get the clindamycin gel? I know it wasn't available for a long time. Is that still available?
Yeah. The problem, Justyna, is this, that once it goes off or out of stock, we tend to forget about it and we go on something that works, so we don't really come back to it. So it's a really bad idea for a marketer of a pharmaceutical agent to let it go out of stock, because out of sight, out of mind, out of stock, out of mind. I haven't seen it for a while, but mainly because we couldn't get hold of it, so we just ignored it. Yeah. And when you get this new stuff coming in, like fluomycin, we use this because it's safe. It can be used in pregnancy. It's pretty effective, and so we go over to something that we trust.
Sure. Okay. So with Polygynax, there's some in vitro evidence. So in vitro, remember, means in the laboratory setting. And then I've also got some another trial that was done. But it wasn't a placebo. It wasn't a placebo-based trial. But this in vitro evidence, they wanted to see in a laboratory setting whether there was bactericidal activity of the Polygynax. So remember, this is a 2 antibiotics, which is the neomycin polymyxin B with an antifungal, the nystatin. And the reason why the nystatin is so nice, and I was so glad when it came up onto the market, was because we were having a massive issue to try and find intravaginal antifungal treatment for your Candida glabratas, which, remember, don't respond to your clotrimazole, fluzoles, etc. So this was great. But obviously, we're not talking about Candida vaginitis at the moment, because that's another whole story by itself. But just the neomycin polymyxin for bacterial vaginosis as well as aerobic vaginitis. So quite a few of the bugs are sensitive to the neomycin polymyxin. This was proven in the study. And they did note in a laboratory setting that there were significant log reductions. So that is volume or load of organism, and that was in 22 strains that cause BV and aerobic vaginitis, which was quite significant. So with the Polygynax, it's usually 1 pessary not IV, intravaginally, sorry, for 12 nights. You know what I mean? I'm talking to the right audience. it made sense to me. Okay, and then this one, also the Polygynex combination, they were looking basically at efficacy and tolerance, so whether it was well tolerated, as a first-line local treatment for infectious vaginitis. Once again, whether it was bacterial and mixed vaginitis, so whether it was Candida together with BV or aerobic vaginitis. And they treated these patients for 12 weeks, and they were looking at the investigator assessment, as well as the patient, basically whether the patient was symptom-free, how they felt, and whether there was microbiological success rates after treatment, which was significant. So the clinical success rate was 97.8%, 95.7% according to the patients themselves, and 81.3% once you did a microbiological assessment after the treatment. So that's also quite supportive of the Polygynex. So that was quite a good one. So it makes me feel quite comfortable. They didn't do a breakdown of the Candida, but we know that nystatin is quite a good product, and especially for the glabrata. So this is normally a product I do recommend for that. And then, but once again, can be used, if fluomycin doesn't work, or if you want to rather use this instead, or if the patient has BV together with Candida glabrata, this is a really good option if you don't want to use your metronidazole.
So, Christine,
yeah.
Justyna, it's quite a long course. Is that absolutely necessary?
Yeah. Yeah, so I think if you're treating BV, probably 6 days would be enough. I think the reason why they've got 12 days there is for the Candida. So I think depending on what you're treating. So I think definitely 12 days for the Candida. If you've got a typical Candida, which we know we can kind of diagnose clinically, if you've got BV, I think 6 days would be suitable. Yeah. Okay. So that's a good question. Thanks, Stephen.
Sure.
Okay, so let's talk about something a little bit more kind of left of center, which is my kind of little protocol. I know you guys have probably heard me saying this, but I'll share it with you. So essentially, we've got a two-pronged approach with treatment. So we know that we want to decrease this abnormal overgrowth, whatever it may be, whether it's the aerobic vaginitis, the E. coli, the Klebsiella, or the Gardnerella from your BV. And then what we want to do is we want to increase your normal flora. And we know your normal flora is your lactobacillus and your bifidobacterium. So how do we decrease your abnormal overgrowth? Well, we've got the fluomycin, we've got the Polygynex, we've potentially got the boric acid. I haven't mentioned your cookie fresh, and that's one that I haven't actually tested in the lab. So what I often do is when I get these questions, I use these products and I grab some candidas that I've got in the laboratory and I sprinkle some stuff on there and I see if it actually works in the lab. Because I'm a curious George, so I try and see if it works, and it actually does work. The products that I'm showing here do work. I mean, it's not exactly, Karolinska Institute research, but I want to have a look and see. So it certainly does do what it says it's supposed to do. But I haven't actually tested the cookie fresh, but certainly boric acid is another really good option for Candida glabrata. And we know that it is a strong bactericidal substance as well. I just don't know whether the concentration in the cookie fresh is sufficient for fungicidal and bactericidal activity. So that's probably something that I need to buy and test in the laboratory and see, and do some more research on that. So I don't know.
You need.
Oh, brilliant! Send it over so I can fiddle in the lab.
I must say, although I'm pushing it, I don't really use it a lot, to be honest. So,
well, yeah. But Steve, I see patients daily with these discharges that Justyna has mentioned, non-STD, and especially pregnancy, and it has become a headache. So that's why I'm so excited by this talk with the data you're presenting.
But this Polygynex seems to be a great option. It's just the
absolutely
compliance might be a bit, but sounds like it's got the right combination as a first line.
And
Any-
they've got 2 courses in one box.
Yeah.
So that's
Yeah.
the other advantage.
Are we worried about resistance if we start overusing it or not?
Yeah, I mean, there is certainly always a risk for resistance. I think yeah, I think certainly, you know, not to use it just to refresh the microbiome, you know, and unnecessarily. I mean, I think if it's targeted for specific infectious cause and reason, and we're using it targeted and for a certain duration, for a specific reason, then I think it's fine. But certainly not just, you know, people start using just to smell good down there or douches for that and whatever, certainly not for that reason. Yeah, I'm assuming these products are on a script basis, are they? Or can you just get them over the counter?
I don't know, Steve. Just to a large extent, depends on the pharmacist, because some
Yeah.
pharmacists are pretty lax and some aren't.
Yeah.
So,
But I think the polygynix would be scripted product, but
And
cookie-
I'm not sure about fluomycin though, because it's an antiseptic. Yeah.
and the
Yeah.
cookie fresh does sound very sort of Dischem over the.
no,
You know, if you
it's
went,
it's in the long aisles of Dischem. It's
if
not
you
even
went
the-
down the aisles of Dischem, Steve, you'd be amazed how many products there are for vaginal freshness, because people feel that they have an odor, and especially if they're working in an enclosed environment, and they come to me and they say, I can smell myself. And I say, well, that's very strange because I can't. And that's where the
Yeah.
Dischems and the people bank on making a lot of money out of these little sachets they sell of all various types of antiseptics and medications,
Yeah.
snake oils that dwell on the on people's feelings, you see.
Yeah, yeah. And I mean the other one, you know, betadine douche, I think, you know, it's always been like, oh, we'll just douche down there, let's just do a douche once a week, you know. And I think there's definitely, just having a look at the literature, there's, you know, that's definitely limited activity. There's obviously the iodine allergy. It's not very effective for BV. It's not something that I would recommend. It does seem to help with initial relief of symptoms and odor, but it doesn't seem to help with the or disrupt that biofilm, and it doesn't, you know, they seem to recur. So it's not something that I recommend at all, the betadine douches. So,
but it has some it's one of those things that's sometimes off the market. So sometimes
Yeah.
you can get it, sometimes you can't. And recently we haven't been able to get hold of it, Steve. So I don't know if it's in people's minds. It used to be, it was very well promoted, but I'm
Yeah,
sorry
it was.
to say
It
that I don't
was.
think
Yeah.
it's available nowadays anymore.
Yeah. I mean, it's anyway, it's definitely very low down on my list
Yeah.
of options.
Thank you.
Okay, so what I've always thought, you know, if you don't have lactobacilli, and lactobacilli decrease your pH, and a low pH fights the bugs. In cases where somebody's really resistant and their microbiome is really in a bad state, often just administration of local live probiotics for a couple of days to basically kill that bug, decrease your pH, and repopulate your flora makes sense. So we've actually tried it with a couple of gynaes. Stephen, I think you might have even phoned
yeah.
actually attempted this as well. I think one of your patients put the tampon in for like an hour and it got so soggy that she couldn't apply
that was the complaint. She couldn't get it in because it was so
Soggy.
It was yeah.
So I think the point is, you know, you don't really need to get that much in there. I think the point is just dip it in quickly, prevent sogginess, insert at night for 7 nights. And obviously, you know, if any irritation occurs, you stop immediately. Remember also, this is a live probiotic, it's a live bacterium. So in anybody who's undergoing chemotherapy, you know, so probiotics, everybody thinks, oh, well, they probiotics are good, they're good. And, you know, even oral probiotics in anybody who's severely immunocompromised can replicate in an immunocompromised host and become an opportunistic pathogen. So we've seen infective endocarditis, bloodstream infections in patients who take oral probiotics. So, you know, I think one does need to be cautious with any live organisms that you are administering. I think in a setting where you can safely administer it for 7 nights, even probably 3 to 5, generally works quite quickly. And I think it's a fantastic way to improve your flora and actually kill. I mean, that's what they do. They replicate, they decrease the pH, and they kill the organisms quickly, whatever you may have in there, whether it's a candida, BV, aerobic vaginitis, trichomonas, whatever the case is. And because it's quite a big bottle, the rest of it, because normally if you've got vaginal dysbiosis, you more than likely have GI dysbiosis as well. The rest of it you can use in your gastrointestinal tract and drink it orally on a daily basis. So that's just something that we've tried. Yeah.
Sorry, Justyna, I've just got a question over here. Lactobacillus inoculation in the vagina. Is it possible that a woman can dip a tampon into some yogurt, Bulgarian yogurt, because that is meant to have bifido?
Absolutely. Yeah. And people have been doing that as well. Before we had all these products available, people used to use yogurts and smear it in there. And it works very well. As long as there's lactobacilli in there, people have used it with fantastic success. I know the feedback that I've gotten with this has been really, really good. And also, I haven't had anybody coming back saying, nobody's come back with any negative feedback other than unable to insert tampon. Does
yogurt make a difference, as it must be Bulgarian, non-sweetened or does it make a difference? Or I suppose you get.
Well, I probably wouldn't put anything in there that's got muesli and bits of strawberry. So probably as bits of strawberry. Probably
must be plain yogurt. Just
plain,
probably as plain and natural as you can.
Non-sweetened, I guess, would also be, because you don't. If you have any sugary stuff, it's going to promote overgrowth.
Yeah. So that's just something that we've tried. Obviously, there's no data for this. Some people might shoot me out the sky, but I think it's just something that we've been trialing. Obviously, major disclaimer, not in anybody who is on chemotherapy, severe biologics, any severely immunocompromised patients, and also not chronically. But I found that people who really, really struggle with a really terrible microbiome, who have recurrent vaginitis, and some of the really resistant candida species, this is the only thing that's worked. So we've had patients who literally have had candida for years, and this is the only thing that's actually helped them. So yeah, it's definitely, I think we just have to be discerning. So
Justyna, there's another question that's just come through. I don't know if you're going to speak about it. If you can, we can defer this question. What about, we've heard about fecal transplants. Are lactobacillus vaginal transplants effective, or is that, because there's been some reports from Israel of if a person has a disrupted vaginal microbiome, getting a transplant, if you will, of vaginal organisms.
Yeah. Absolutely. So that is something that can be done. It's not something that is done in South Africa at the moment that I'm aware of. I suppose this kind of scenario would be almost like a transplant. Remember, it's with a GI transplant, it's a lot more, I would say, complicated, because you are dealing with so many different organisms. In this situation, I think it's a lot easier and simpler, because it is so minimally diverse. So we don't need that many organisms to improve your microbiome in terms of the vagina. So in a way, this is kind of like a transplant, but certainly, yes, it can be an option. Yeah. Once again, obviously to screen for STDs and everything else.
So Tina, I've thought for a long time whether we shouldn't start doing this for patients through current urinary tract infections, and indeed I see it does decrease the pH as well. And
so do you think it's good for
well, I've not done it yet, but I've been toying with it for some time, and I'm not sure if it's something that we should even think about. Do you have any immediate thoughts?
I mean, so So, Stephen, I must say a lot of people who get UTIs have abnormal perineal flora. And in saying that, they've probably got abnormal vaginal and GI flora as well. So I think often if you sort that flora out, you find that their UTI symptoms actually settle and they're less likely to get recurrent UTIs as well, because that comes from the perineal flora, which is often linked to your vaginal and your GI flora. So I think one definitely needs to look a little bit further than the urinary tract when you have recurrent urinary tract infections, because I think it definitely stems from the surrounding microbiota.
Just Steve, on that topic, Justyna, we do know, and Steve will back me up, I'm sure, that topical estrogen in the vagina is meant to reduce the incidence of UTIs. Is that correct, Steve?
Yeah.
It does. Okay, so
Yes,
then
And
some
that works by pH,
absolutely.
that works by pH reduction
so
because it
And that goes to show, that
so
your
theoretically,
vaginal flora is directly linked to what's
yeah,
happening in your urethra.
yeah. So theoretically, Gynaflor, which is estrogen plus a probiotic, should theoretically work very well. You haven't mentioned Gynaflor because that is
No,
something you've got to
I'm not
keep in
aware
the
of that.
fridge.
No.
Yeah, it's something you keep in the fridge, also for nearly 2 weeks, 12 days. And it's an topical estrogen plus a vaginal probiotic. So theoretically, I know it's flying off the shelves, which is probably an indication of its effectiveness. So
Yeah.
that's called
Yeah,
Gynaflor.
that makes a lot of sense. I would have to look at the literature and see if there's anything, if there are any trials. But it makes, in theory, that makes a lot of sense, especially for your menopausal elderly patients. Absolutely, yeah.
Yeah.
Because they will have low lactobacilli and the estrogen levels will be low, and you'll be replacing both of those, and that's exactly what
Sounds
you need.
intuitively like a good idea.
Absolutely. Okay, so coming to my last slide. Essentially, we know that it's very common. It does cause a significant amount of morbidity and discomfort, and it certainly can be managed. We've got a lot of different options. And I think looking at a tiered approach and thinking about it rationally, sensibly, and just using what you can. And if one thing doesn't work, then trying something different and not being afraid to step out into something slightly off center and something different. And if you have any questions, if you need some help, reassurance, then you're always welcome to contact me. I'm available all the time. That's me.
Justyna, thank you so much. And you've given us a lot of food for thought. We've got a few more questions. Steve, can I open the batting for the
yes,
question?
please do.
Some people it says this question, what about other alternative therapies? Do you have any experience in your practice about using things like garlic and other
Where do you
so-called
put the garlic?
in the vagina? Where did you think, Steve?
No, I'm just
It
that's
used
the
to.
first I've heard of it, but
Have you heard about Justyna?
I'd rather go for
I
yogurt.
haven't. I know that garlic is antibacterial.
Yeah, that's the point.
I don't know if it's an irritant to the vaginal wall. That would obviously be something to consider. I suppose, honey is also a really good antibacterial. We know that we put it on wounds. It works really well as an antibacterial. Nothing grows in honey, so that would be another option.
Nothing grows in
Yeah,
honey, really. So if you put
yeah,
honey on one of your petri dishes, nothing's going to grow in it.
nothing will grow.
Wow.
Yeah.
Why is that, if I may ask?
I think it's got natural antibacterial properties. They actually used to use honey on wound dressings. It's actually quite incredible. It works really well. But garlic would be an interesting one. I'm not sure if it would sting at all. I don't know. I'd have to probably get some garlic and test it on some of my bugs in the lab. So that's a good
Exactly.
question. I don't know.
I'm not sure if the vagina does it have sensory nerves, Steve? I suppose it does.
Yeah.
So I'm not sure if garlic would be an irritant and pro-inflammatory from that point of view. But I mean, if you're going to put in other things in the vagina like yogurt, there's no reason why honey and garlic shouldn't also be tried.
Sure. Okay. Interesting.
Goodness me, we are pushing the boundaries here.
Yeah. Now, one of the things we spoke earlier about douche, the one thing I'd like to also hear your opinion. If a woman has a very, very heavy infestation, I suppose washing it out physically with a douche also would be useful. Would you say so?
Absolutely. Yes, yes. So absolutely. So as part of the management, you want to decrease the burden, decrease the load first. So that's when I would definitely recommend washing, douching, get rid of the load, then kill, then repopulate. So it's kind of that
that's
that
quite a good
prong,
point.
that tier. Yeah.
Yeah.
So that's quite a nice little principle you've just shared there. I think that
Thank
really
you
is
for
that.
that.
That's a really good little strategy.
Yeah.
Thanks, Justyna.
Are we doing the sampling correctly? Do you want to just give us some little tips about that? You know,
Sample?
well, when you're actually
Swab.
taking your swab,
Yes, sure. I can go through that. No problem.
sometimes I open the
Yeah,
door and
so
I'm wondering what I've got there, if what I've got is the right thing. And, sometimes I take 2 or 3 because I'm not sure if I've got the right little
What would you
bottle.
recommend?
Yeah. You can go.
So definitely not a dry swab. So remember, if it's dry, then the organisms are unhappy and they die because it's dry. So just remember, dry.
Right.
Generally, we will need a gel swab. So remember the gel, it's got jelly, they're nice and happy and they're moist. Remember the vagina is like a moist, happy, warm environment. You want to take a gel swab. Ideally, you want to take as high into the vagina as possible. That's where the organisms will lurk. And you put it straight into the gel swab, into the jelly, and send it straight through for a vaginal MCNS. Obviously, we want those organisms to remain in the jelly so that the anaerobes, like Gardnerella vaginalis, doesn't die along the way to the laboratory, and that we can do a proper vaginal MCNS for you. If they're dry, then they will die along the way, and we may give you a negative result when there's actually something there, but it's died along the way, and we give you a false negative.
Does Justyna, does Lancet supply the correct gel? Because I suppose you get gels and gels.
Yes, yes.
Gel Steve puts on his hair. So they do
Yeah,
supply.
so we supply the gel swabs. It's actually the blue ones. Obviously some organisms are non-culturable, but those are usually the STDs. Those ones, we can do on urine where we do a PCR. We do the other like mycoplasmas and ureaplasmas, which are the kind of other options. So those can be done on a PCR, and those are on the dry swabs or the urine. And the reason why we use dry for PCR is because the jelly clogs up the PCR instruments. So jelly never for PCR, and
Okay.
dry never for culture.
Yeah, very
Okay.
good principles. Yeah.
Now, there's another question over here. When would one send a urine sample for this sort of work, or is that just for chlamydia and other UTI sampling?
Yeah. Okay, so that's a good question. So remember, if you want to know what's happening in the vagina from a flora point of view, like your BV, your candidas, etc., it's best to take a vaginal sample for an MCNS. Your STDs, they will be replicating, and often an STD will be in your urethra, it'll be in your perineum, it'll be in your vagina. So in that case, you can take a non-invasive sample like a urine, and then we can pick up your herpes, your chlamydia, your gonorrhea on a urine. So for your STDs, we can do that on a urine. Non-invasive sample. But if you want to know about your BV, your candida, and what's happening in the vagina itself, then a vaginal MCNS. I hope that answers the question.
Thank you very much. One final question, Steve. I don't know, that's the end of my list. On the subject of hygiene and bathing, is bathing an effective way of cleansing one's perineum and one's vagina, or is showering inherently a better option? What do you think?
I think they're both equal. I think just a normal soap and water is absolutely fine, and washing the perineum properly with soap and water is absolutely perfect. I definitely wouldn't kind of shove the soap deep into the vaginal area and kind of think that you're doing a cleansing job there. I think the reason for that is you are going to disrupt the lactobacilli that are there. And you're going to affect it, remember, because the soap is generally quite alkaline, so you're going to affect the vaginal flora. As long as you're washing your perineum and making sure that there's no fecal matter in that area, keeping it clean with normal soap and water, whether you do it in the shower or whether you do it in the bath, it doesn't really matter. Some people will notice if you're using extra fragrant soaps or bath salts or whatever that can aggravate and cause an irritation. Other people not as susceptible. So, it depends on what your body is as capable of dealing with. and you'll know whether you're getting an inflammation or not, and just take it as it is.
Great. We've got one last question here, unless you've got another question, Pete.
Let me just quickly finish this question
Yeah,
before you
great.
do your... Recently, SASOC put an announcement out about scented Tampax and scented vaginal towels. Did you see that, Steve? And there's been a bit of an outcry in terms of the use of certain chemicals in vaginal Tampax and vaginal towels. Do you think, in your opinion, what is your opinion about scented and fragrant sort of surfaces on these? Is it a bad idea, or inherently does a non-scented product promote less infection? What do you think then, Justyna?
I definitely think we shouldn't be adding anything. If we can avoid it, we shouldn't be putting anything, whether it's preservatives, fragrances, oils, smells. There should be nothing in there, you know, as simple as you can make it. If it can just be a simple cotton pad, cotton tampon, just leave it as it is, because, you know, the more you add, the more you disrupt. So just leave it as it is, as simple and natural as you can.
Yeah, they're called hormonal disruptors, and there's a whole class of chemicals that do cause that.
No, you don't want to mess with your microbiome in the, you know, we already have so many chemicals in water and in food and stress.
Yeah.
You're
Steve,
right.
the last one.
No, one last question from an anonymous attendee. Could the menstrual cup be associated with the change of vaginal flora and disrupted vaginal discharge?
You know what? I think they generally are sterile when you put them in. Obviously, any foreign objects, if you keep it in for a long period of time, organisms do like foreign material, and they will attach onto them. They will create biofilms. So it's a matter of just making sure that it's not kept in for a long time, and it's removed, you know, after basically
How
don't
long
keep
is a
it in
long
for too
time?
long.
How often should you? And secondly, doesn't the menstrual blood act as a sort of a culture medium, a sort of
Absolutely, yeah. So, you know, if you can change it every 3 to 4 hours, then that would probably be the best option. Yeah.
And then you just wash it with soap and water, or just water, or
soap and water, yeah, soap and water, and then just rinse the soap properly so that you're not putting anything back in. And also in the least fragrance, so just a normal, I would say, glycerin, plain non-fragrance glycerin soap. So you gets rid of the surfactant, breaks down the biofilm, and then regularly change it. Yeah. But I don't think it's, if it's got nothing on it, it shouldn't disrupt the microbiome too much. Obviously, as you say, you don't want the blood build up, and then just rinse properly with glycerin and then reinsert. Yeah.
Great. Thank you. Yeah, I think that's the end of the questions. We really enjoyed that. You know, these are really bread and butter discussions that we're having. We see these patients all the time, and often we're guessing, but you've given us some great pointers. And you know, we've really got a lot to work with here. And we thank you for your time and for the enthusiasm with which you have given the talk.
Yeah, it's a great eye opener.
You certainly make microbiology much more interesting than
it
was ever my day as well.
Your day.
So yeah, we really thank you for that, and thanks for taking the time to be here tonight, Tina. Any other last words, Pete?
Yeah, Justyna, I think it's been wonderful, and it has broadened our minds. I mean, you know, we unfortunately think about Western medicine as antibiotics or nothing. And this question about yogurt and other things that you mentioned is a wonderful broadening of one's mind. And, you know, we must think Gynaflora, we must think Polygynax, Fluomycin. All these things are products we should have as part of our armamentarium, Steve. And any woman's health practitioner will come across these discharges, and I see them every day. And it's nice to know that you don't have to go and use Flagyl or what have you. You can use other things, especially in pregnancy, which are effective. So thank you very much indeed. A final thank you to the Pelvic Floor Foundation, our sponsor, and of course Chris, who's put everything together. Steve, thank you for being with us.
Thank you as well, Pete. Thank you. I'm reading the Argus.
The August.
Yeah.
The only August I do is reading the newspaper on the weekend. Okay. So, Justyna, it's wonderful to have you with us. And we hope, please God, that we can have you again sometime this year.
Oh, Absolutely, yes. If there are any queries or specific topics that you are interested in that are confusing, then just let me know and I will be here. And my details are there. If anybody wants to contact me, you're more than welcome. And thank you so much, Chris. Thank you, Pelvic Floor. Thank you, Stephen. Thank you, Peter. It's always nice to see you. And have a lovely evening. And to the listeners, thank you for listening.
So, ladies and gentlemen, a great big thank you to our amazing, immaculate microbiologist. She's been wonderful. Those are her words. And the exploring the alternative options for women that don't use antibiotics. Thank you very much indeed, and good night.
Thank you
Safe
very much.
home, Steve.
Thank you.